everyone. Thank you for being patient as I was just in the previous call wrapping up the session. I will go ahead and start today's session. As most of you know, my name is Sarah Eisinga, and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And today's educational session is on Lymphoma 101 for newly diagnosed patients. Now, before I introduce today's speaker, there are a few things I'd like to bring to your attention. This session is being recorded, and the recording will become available following the conference. You will receive an email when this becomes available, and we hope at the end of the presentation there'll be a few minutes for a question and answer period. So you can ask your questions by typing them in the Q&A chat box at the bottom of your screen. I'd now like to introduce to you and welcome you our speaker, Dr. Chantalle Menard. Dr. Menard is a hematologist at Cancer Care Manitoba that provides clinical services within the lymphoma, leukemia, and bone marrow transplant disease site groups. Dr. Menard has a specialty in quality improvement and completed her Master's of Science in Healthcare Quality program at Queen's University. Her quality improvement endeavors at CCMB are aimed at reducing diagnostic delays, clinical guideline development, and improving delivery for patients with hematological malignancies. Thank you very much for joining us today. And Rebecca, you can unshare your screen so that Dr. Menard can share her slides.
All right, thanks for having me today. I just want to apologize in advance for my voice. I'm recovering from laryngitis. 3 days ago, I didn't have one, so this is a marked improvement, but if I have to stop and drink some water, I apologize in advance. Okay, so today we're going to talk about what is lymphoma. We're going to discuss the most common ways that lymphoma comes to our attention. We're going to look at how lymphoma is diagnosed. We'll discuss what tests that we do for patients with lymphoma. We'll briefly touch on some treatment for lymphoma, as well as the outlook after a lymphoma diagnosis. So first up, what is lymphoma? So the first thing we really need to understand is where it comes from, and it's a disease of the lymphatic system. Now, the lymphatic system is a very important component of our body's immune response, and it's the circulatory system for our immune response. It's composed of cells, which are lymphocytes, lymphatic fluid, lymph nodes, lymphatic vessels, and specialized organs like the spleen, the thymus, which house different immune reactions. So the lymphatic system collects excess fluid that drains from cells and tissues throughout the body and returns it to the bloodstream, where it is then recirculated through the body. It cleans the excess fluid of foreign invaders like germs and bacteria, abnormal cells, and waste products. And it transports lymphocytes made in lymph organs like the marrow, spleen, and thymus to other areas of the lymphatic system. What then are lymphocytes? So these are white blood cells that fight disease-causing organisms like bacteria, parasites, and fungi. There are 3 different types of lymphocytes, and they all have different functions. So B cells, which are responsible for the antibody immune response. When we measure immunity, it's typically based on antibody levels like titers. And B cells are the cells that are responsible for producing those antibodies. But B cells also rely on T cells to help them identify foreign invaders and help them determine bad from not bad, self from not self. T cells then are a workhorse. They have many different functions, but importantly, as I mentioned, they help B cells do their job, and they're also responsible for directly destroying bad cells and bacteria. So they assist in what's called the adaptive immune response, and are part also of the body's innate immune response because they can directly kill foreign invaders. And then finally, natural killer cells. These are a more primitive lymphocyte. They've evolved with the human race to identify certain patterns of abnormal things that we've been exposed to throughout time. So they don't learn so much as they recognize historically abnormal things and destroy them. They're also a very important line of defense for the immune system. What then is cancer? Well, cancer, the definition of it is truly just uncontrolled division of cells that form tumors and invade other tissues. And they can spread throughout blood and lymphatic systems. They result from changes to cellular DNA or genes, and that causes a mutation. And the mutations that allow cancer to develop are ones that allow rapid growth, ones that remove the control on cellular growth, and mutations that impair DNA repair. A small percentage of these mutations are inherited from parents, and they're called genetic, and there are some genetic cancer syndromes, but the vast majority arise from environmental exposures after birth. And the exposures typically include common things that we know about, like smoking and radiation, but certain viruses as well, some environmental carcinogens that we're exposed to, as well as hormones and chronic inflammation and potentially obesity. With regards to lymphoma, there is not a known genetic syndrome for the majority of patients that develop lymphoma. It happens usually as a result of potentially environmental exposures, but people may have an individual susceptibility to it based on their underlying genetics. So lymphoma is a cancer of lymphocytes. Here is a picture of a normal lymphocyte. And here on the right here is a picture of very abnormal lymphocytes. So you can see that they're a lot bigger than a normal lymphocyte. We call this vacuolation, which can be a marker of how aggressively the cell is dividing and changing. And then with the brain of a cell, which is the nucleus, is much bigger and disorganized in these cancer cells. So a lymphoma typically involves a lymph node or a lymphoid organ like the spleen, but it can also occur outside of a lymphatic structure, and we call those extranodal lymphomas, and that can happen in the skin, in subcutaneous tissues. So lots of different presentations for lymphoma, but it's a cancer of lymphocytes. Lymph nodes are about 1 centimeter big lymphatic structures. So they're normal to have lymph nodes. You have many lymph nodes all throughout your body, and they contain lymphocytes, and they're the site of an immune response to infection. So it's normal to have lymph nodes, and you can have a reactive node that enlarges because there's a lot of active immune fighting that's happening in that lymph node, but it would typically come back down after a period of time. And places where we can feel lymph nodes that we're often examining patients for are the neck, the armpit, and the groin. But as you can see, there's a lot of lymph nodes in places that we cannot feel. I did just want to touch briefly on lymphocytic leukemia. So when there's a cancer of lymphocytes, but it does not really involve lymph nodes so much as it involves the blood and the bone marrow, it's then called a leukemia. But there is a lot of overlap in presentations and in lymphomas that have both a leukemic presentation and a lymph node presentation. So some lymphomas are more likely to present with blood and marrow involvement, and then we call that a leukemic presentation. So what are the signs and symptoms of lymphoma? So most often, if a patient is the one that notices the abnormality, it's because there's a new lump or bump, typically in the neck, in their armpits, or in their groin. Sometimes their abdomen feels enlarged, and they might get the sensation of bloating or getting full quickly. And that's often due to the spleen enlarging, because it doesn't allow the stomach to enlarge to accept as much food as before. There are some symptoms that we call red flag symptoms for a more aggressive type of lymphoma. And patients might be experiencing unexplained fevers. So these are fevers that are happening in the absence of any infection, and typically are happening for a length of time that is not really in keeping with an infection. Night sweats, which are drenching. And so for when we talk about sweats related to lymphoma, we mean sweats that really cause you to drench the sheets and your pajamas and have to change your pajamas or the sheets in the middle of the night. And then weight loss. And so there's usually our cutoff for weight loss concerning to lymphoma is about 10% of your body weight in the preceding 3 months. And So that's something that a patient might bring to us as a concern that might raise a suspicion for a lymphoma. All of those, though, are non-specific, which means that they can be seen in other disorders other than lymphoma. And then in more advanced lymphoma presentations, people might have symptoms due to compression of a structure or an organ by a lymph node. And so that can result in swelling in the legs, which is due to obstruction of lymph returning back up to the body because of large lymph nodes, or perhaps a lymph node that's in an area that's causing obstruction to a kidney, so it could cause issues with kidney function. So how do we diagnose lymphoma? So as we've talked about the way that patients can present, we can suspect it based on patient's symptoms and physical exam findings, which are very important. So a large lymph node in a palpable area. CT scans might be done sometimes to investigate symptoms or physical exam finding, or sometimes we suspect lymphoma based on a CT scan that was done for another reason, and then we see an enlarged lymph node on the CT scan. And then there are blood tests that we can think about lymphoma, or we might suspect lymphoma. And so those blood test abnormalities might be a high lymphocyte count in the blood. Sometimes there are markers in the blood that tells us that there is a very rapidly dividing cell. And so we are looking at markers that show us what that might demonstrate that on the blood work. But a definitive diagnosis, so to know for sure what we're dealing with, always requires a sample of tissue, which is a biopsy, or sometimes a fluid, which is then examined in a clinical laboratory. So the best results for a diagnostic biopsy are with a large sample. So that is typically cutting out a node or taking a very large sample of a node. And the reason that we like a lot of sample to do these, to diagnose lymphoma is that there are a lot of specialized tests that the pathologists have to run for us to be able to categorize the lymphoma into all of the specific subtypes of lymphoma that there are. And that's important because we treat lymphomas differently depending on what type you have. So that's why we can't just, say based on presentation or history or symptoms, this person has lymphoma and we should just start treating them. We always need some form of pathology because that helps us decide how to treat them and in what way to treat them. Sometimes a lymph node is in an area where it's not possible to cut it out. And those lymph nodes sometimes are the only things available to be biopsied. And so in that case, you might have a needle-guided biopsy. Those are usually done under ultrasound or CT guidance. So it's a day procedure. You'd go into an imaging center, typically at a hospital, and they would use a CT or an ultrasound to see where the lymph nodes are in the body, and then use that as a guide to advance a needle in and take some tissue. We don't like to start with needle course if we can avoid it, just because if you can imagine, what you're getting is a pretty small sample of a larger lymph node, and we might not get enough tissue to be able to run all the tests that we need. Less common places to biopsy, so a bone marrow biopsy can be done sometimes as part of staging investigations, but that's not as common anymore because we have other ways of doing that now. But sometimes if there's a lymphoma that's presenting mostly with blood abnormalities, blood count abnormalities, that's when a bone marrow biopsy can be used for diagnosis. And then we can do a special test in the lab called flow cytometry on fluid. So that fluid can be fluid that can be blood. It can be fluid that we get from an area like around the lung or from the brain, around the brain. And it goes through a special machine that can test and see what markers the cells have on their cell surfaces, and then tells us whether or not they are a cancer process or not. So lymphoma diagnosis, as I mentioned, requires tissue. So what we see here on the left is a large lymph node that's been excised, and this is a normal lymph node. And when a pathologist is reviewing a lymph node, they're looking at what's called the cell architecture. And so what that means is how the cells are arranged in a lymph node, because in a normal lymph node, they expect to see normal arrangement of cells. When a malignant or cancer takes over a lymph node, the normal cell architecture changes and is disrupted. And so that's a first clue to the pathologist that there's something abnormal here. And then they have to do special stains to allow them to identify what cells are in the lymph node and what process is going on that's making the lymph node abnormal. On the right here, this is a sample of a core biopsy. So what you can really tell that the tissue you're dealing with is a lot smaller with a core biopsy. If you think about it, it's like taking a needle right in through the middle of a lymph node. So you're really only getting a very tiny piece. So you could miss the cancer process altogether if you take a lymph node, if you take a sample from an area just adjacent to the abnormal cells. Or sometimes, just because of how small the sample size is, maybe they can say, well, it looks like lymphoma, but we can't characterize it or put it into any of the specific categories that we have because we don't have enough tissue to run all the tests that we need. So if that happens, sometimes if patients are feeling well and we have the time to do it, we might look for another biopsy. Sometimes we have to go ahead and make treatment decisions based on kind of incomplete pathology results if a patient has a lot of symptoms and needs to start treatment urgently. So I mentioned that there are a lot of different types of lymphoma, and there are a lot of different ways to classify lymphoma. So most commonly, patients talk about Hodgkin's and non-Hodgkin's. Hodgkin's is only one specific kind of small type of lymphoma. Non-Hodgkin's is a much bigger pool of lymphomas. So we break non-Hodgkin down into even more subgroups and more classifications. The majority of non-Hodgkin's lymphomas are B-cell lymphomas. So the majority of cancers that we see are in North America are non-Hodgkin's B-cell lymphomas. There are a smaller percentage of cancers that present with T-cell lymphoma. And then within B-cell and T-cell lymphoma, there are several different classifications. And again, it is actually really important to know which subtype of lymphoma you're dealing with, because all of our treatment that we use for patients are based on the specific subset of lymphoma that we have. And here's another classification system that we sometimes use, and maybe your doctors might have said this to you in the clinic. We talk about lymphomas being indolent or aggressive. And so indolent, historically, this means that these cancers are slow growing, so patients can have them for a long time before we become aware of them. And they're often diagnosed at more advanced stages because they don't have a lot of symptoms associated with that. So when we make the diagnosis, patients might have lymph nodes in more than one area, and often they do not have any symptoms associated with it. And sometimes patients are just observed at diagnosis. And indolent lymphomas are usually not considered curative, but they are responsive to treatment. Versus aggressive lymphomas, these typically have symptoms. So patients will usually identify that they have symptoms associated with their disease. They might have noticed the lymph node growing rapidly. These cancers need to be treated quickly, and they are curable. So what tests do we require once we make the diagnosis? So everything that we do once we know that this is a lymphoma initially is just based on staging a patient, which helps us to get a sense of their prognosis, as well as sometimes it changes the treatment that we use depending on the stage. So stage 1 is involvement of a single lymph node region or one area outside of a lymph node, like the spleen. Stage 2 is 2 lymph node areas, but both on the same side of the diaphragm. So it can be above the diaphragm or below the diaphragm, but the diaphragm is really the defining marker there. Stage 3 is involvement of both sides of the diaphragm. And it can also include a spleen or another localized area of non-lymphoid tissue. And then stage 4, which is the most advanced stage, where this is what we call cancer that's outside of a lymphatic area. So it might be cancer that's spread into the liver, the lung, or the skin. Any cancer diagnosed at with bone marrow involvement is automatically stage 4. It's quite common for lymphomas to be more advanced stage because the lymphatic system goes throughout the body, so it's easy for the lymphoid system to kind of be in more than one place. Most patients will have had CT scans, so these are usually done at diagnosis and then sometimes done throughout treatment as well to assess response to treatment, or at the end of treatment to assess response. And so what this is really is just x-rays, but it's thousands of x-rays taken many different cuts. And then that produces an image that we can look at, and I'll show you that next. That shows us, there's images, CT scans here. So here we have a CT of the chest, and this is a large lymph node in the chest. There's some extra fluid around the lung. These black areas are the lung here, and there's some vessels, and the heart would be here if we kept going down. So we can scroll up and down in the image and really get kind of cross sections of people's cancer. Here, this is a cross-section of a CT scan of the abdomen. So it's pointing to a lymph node area that's back here around this is the aorta. So this is kind of in the back area here. These are kidneys, there's a liver and a spleen. So we would look through all of that to make sure that we can identify any abnormal lymphoid tissue and the size of lymph nodes to help us for staging purposes. And then any aggressive lymphoma, and more often now with indolent lymphomas, we use PET scans. So PET scans use a harmless radioactive sugar, and they basically highlight active tissue. So it's not specific because any area of increased uptake will light up. So including like the brain lights up on a PET scan, but that doesn't mean that there's lymphoma there. It's just because the brain is obviously very metabolically active. Infections can also light up on a PET scan. So that's why we like to make sure that patients are not sick with an infection at the time of their PET scan so that we get an accurate representation of their lymphoma. We also like to make sure that patients' blood sugars are under good control. Otherwise, we might see a lot of non-specific uptake that doesn't mean much. And there are some medications that patients take that may affect a PET scan as well. So patients are usually asked about that before they go through the scanner. PET scans are standard of care for instance, Hodgkin's lymphoma and most aggressive lymphomas. They typically serve as a baseline and can upstage someone because they can identify things like bone marrow involvement that we otherwise wouldn't be able to do unless we took a sample. They are being used, as I said, a little bit more routinely for the indolent lymphomas now because they are sensitive for really all lymphomas. The degree of activity might just change depending on how aggressive or non-aggressive the lymphoma is behaving. Less commonly, you might have an MRI done for your lymphoma. So this uses magnets. This is the test that some patients do find a little bit challenging. As you can see here, you're completely enclosed inside of this MRI machine. It's quite loud, and patients that have claustrophobia might find this much more challenging. It's not a routine test for staging, but there are some things that we want MRIs for because it's better than CT. So for instance, if we're concerned about central nervous system or disease of lymphoma in the brain or the spine, an MRI is the best test for that. Additional tests that you might have to undergo include a lumbar puncture or a bone marrow biopsy. So as I said, bone marrow biopsy typically done if patients have abnormal blood counts and we're trying to make a diagnosis. And lumbar puncture would be done if we wanted to see if there is any lymphoma cells in the fluid that surrounds the brain. Both of these are day procedures. Typically, they're done by your lymphoma team. are typically pretty well tolerated for patients, but obviously can be anxiety provoking to have to undergo these. We also need to do a pre-treatment fitness assessment because a lot of the treatments that we want to use can potentially damage organs, and we want to make sure that patients are fit enough to receive the treatment that we want to give them, because chemotherapy affects various organs in the body. So we want to make an assessment of how well the heart pumps. So you might have had a MUGA scan, which is a radioactive injection with a scan of the heart, or an echocardiogram, which is an ultrasound of the heart. Both can tell us the ejection fraction. Your lungs might need to be assessed with pulmonary function tests, which tells us how well they exchange air and how good your lungs are, which is particularly important if you're getting some treatments like in Hodgkin's lymphoma or if you've had a history of cigarette smoking. And then there's blood tests that we need to do to look at the liver and the kidneys and your blood counts. And sometimes we have to modify treatment based on the pre-treatment fitness assessment results. How do we treat lymphoma? So most treatments involve systemic therapy, and that's with chemotherapy and sometimes cellular therapy. Now, local therapies are useful in special cases or as an adjunct like radiation therapy, but surgical treatment is rarely done for treatment. And a lot of patients ask that in their clinic appointment, can't you just cut it out? And it's typically not the case that you can cut out lymphoma because it would come up somewhere else. And that's just the nature of lymphoma. So it's not usually a treatment, although some patients do have surgical procedures done at diagnosis or because they present with something that requires a surgical intervention. And then another form of treatment that I always like to really stress is something called active observation. So for some patients, this is the right path. When we know that their lymphoma is an indolent or slow-growing lymphoma and is not curable, we know that it's best to wait to start treatment because it does not change outcomes and it does not change anything to do with how their lymphoma will behave in the future. And so we might put them on a course of active observation where you're seeing your doctor regularly and monitoring for changes, but not receiving any systemic treatment. So in terms of treatment, I talked about this being a very important distinction. So an aggressive lymphoma versus an indolent lymphoma. So for aggressive non-Hodgkin's lymphomas, and the most common of this is diffuse large B-cell lymphoma, these diseases can be fatal in weeks to months if they're left untreated, but they are potentially curable with chemotherapy. Indolent non-Hodgkin's lymphoma, so slow-growing non-Hodgkin's lymphoma, and an example of that would be follicular lymphoma. Patients can live for many years without treatment, and again, often without even knowing they have the diagnosis. It's not curable, but typically responds well to chemotherapy. And we know that treating earlier does not result in better outcomes, and so active observation at diagnosis is appropriate in many cases. For follicular lymphoma, the average duration of time that someone can be observed without needing treatment from diagnosis is about 2 years. Hodgkin's lymphoma, again, is the specific subset of lymphoma. This is an aggressive B-cell subtype, and it requires treatment at diagnosis right away with chemotherapy, sometimes with radiation therapy. And I just have a picture here of the lymph node diagnosis in Hodgkin's lymphoma. Hodgkin's is one of those ones that's harder to make the diagnosis because the abnormal cancer cells, which are these little owl eyes here, there's very few of them in a lymph node that's enlarged from Hodgkin's lymphoma. The majority of the cells that we will see in a biopsy of a Hodgkin's lymphoma are inflammatory cells. So that's why sometimes people need multiple biopsies, or we really want to push to get a full node excised cutout so we can make that diagnosis. Now, radiation therapy is done. External beam radiation is most common. Radiation, this means that radiation is given from outside of the body. And the treatment courses are typically several sessions over sequential days. The lymphomas are typically very sensitive to radiation therapy. And so because of that, they can use lower doses. So some of the side effects associated with radiation are less than with other types of cancers, which is good. We use radiation sometimes to get quick reduction in the size of a tumor if it's causing pain or potentially damaging an organ or something like the spine. We would maybe radiate first to get just local control. The other place that we use radiation therapy can be in localized disease, where we use it sometimes in addition to chemotherapy, or in some lymphomas, that can be the only treatment received if it's a single site. Now, chemotherapy is done when local therapy is not enough to cure the lymphoma, even if there would be initial response. So systemic treatment with chemotherapy is usually indicated for long-term remissions or cures. So chemotherapy, when patients think about cancer and treatment, this is what most people think about. So these are the things that are associated with the classic side effects of nausea, fatigue, some cause hair loss, potentially infections, and low counts. So these are combination chemotherapy drugs that are given at pre-specified intervals, usually intravenous, although sometimes with some oral medications as well. They typically require a patient to come back and forth to a cancer center for their infusions. And the side effects are, again, those more classic side effects, but again, they're specific to each medication. I think that's really important for patients to know because, at this point in this day and age, most people know someone who have been through chemotherapy for a cancer. And sometimes that has left kind of a opinion of the patient of what to expect. And it might not always be right because each chemotherapy has its own side effect profile. And then another really important adjunct to a chemotherapy that we use for lymphoma is steroids. So lymphoma is exquisitely sensitive to steroids. And so sometimes we give patients steroids at the start to try to improve their symptoms or reduce the amount of disease they have right off the bat. And then every cycle of therapies usually includes some form of steroids. Now, the other form of systemic therapy is immune therapy. So we typically use these in combination with chemotherapy. So the examples that you might have heard of are rituximab for B-cell lymphomas and brentuximab vedotin, which we use for Hodgkin's lymphoma. So these are proteins that bind to different markers on a cancer cell surface, and they trigger the body's immune system to attack and destroy the marked cell. So it's pretty cool. It's using the body's own immune system, like T cells, and we talked about T cells and how they're responsible for destroying abnormal things in the blood. So it's utilizing the body's own immune system, which is a pretty advanced system that's been developing and evolutionarily developing over a millennia. So that's pretty cool. And it's really revolutionized lymphoma therapy over the last 20 years. And it's first line for most lymphomas, but there are also second and third line therapies with new and evolving technologies that are being developed. Other forms of therapy, often not first line, although depending on patient status, they might be. They're called small molecule inhibitors. These are usually oral pills that target specific enzymes that are required for the cancer cell to divide and replicate. There are different drugs available for different enzyme targets, and they've been studied for different types of lymphoma. The most common ones that people might have heard of are BTK inhibitors or Imbruvica, which is ibrutinib as well, PI3 kinase inhibitors like idelalisib or Zydalig, and then BCL2 inhibitors like venetoclax or Venclexta. So for patients who cannot tolerate chemotherapy, sometimes a small molecule inhibitor is a good first choice, but most of the time we save these for second and third line in lymphoma. Now, cellular therapy, we typically reserve for relapsed and refractory cases of lymphoma. There are two different types of transplants that we can do. So one is an autologous stem cell transplant, and that's when a patient receives their own stem cells back And so the principle of an autologous stem cell transplant is to give high doses of chemotherapy that would wipe out all of the cancer cells, but is also potentially toxic to the bone marrow. So the first thing we have to do is to collect someone's stem cells from the patient, and then we rescue them following their high-dose chemotherapy by reinfusing the stem cells after chemotherapy. This obviously is associated with quite a bit of toxicities, and patients must be pretty fit to undergo this, and everyone's not a candidate for autologous stem cell transplant. Allogeneic stem cell transplant is when you get someone else's stem cells. So this treatment is a combination of high-dose therapy used to destroy residual cancer, but also rescuing patients with someone else's stem cells, with the principle being that this new stem cells will come with a new immune system that hopefully will be better at recognizing the lymphoma as bad and preventing it from reoccurring. There are many complications that can be associated with an allogeneic stem cell transplant. And again, not everyone would be a candidate for this. And it's also not effective in all types of lymphoma. So there are some lymphomas that we know that allogeneic stem cell transplant can be a path to cure. And then there are others where we don't think that it will result in cure. So we reserve it just for the cases where it's appropriate to use it. And then the new kid on the block, and almost not a new kid anymore. It's been around since probably about 2017 is its first year in use. So CAR T cell therapy, which is using genetically engineered T cells that we collect from the patients that are basically they teach the T cells to recognize and destroy cancer cells, which again is pretty cool. There are new indications for this every year with new diseases being studied. There are a lot of modifications to the products that are going and evolving therapies on the horizon. And there's also, this is getting autologous or your own T cells back, but there's an evolving area where they're looking at giving off the shelf or pre-made T cells that are already made to target specific cancer cells. So those have a lot of potential because there would be easier for patients to receive if we didn't have to go through the process of first collecting someone's T cells. So receiving CAR T is quite complicated. We, as I said, have to collect their T cells, and then we actually manufacture their CAR T product. And that's only done in specialized plants around the world. It's time consuming, it's expensive, and then delivering the CAR T product itself is very complicated. And there are only specialized centers that are approved to do so because there can be a lot of specific toxicities associated due to an inflammatory reaction that can happen when you receive the CAR T cell product. So what is the outlook after a lymphoma diagnosis? And the truth is that it varies markedly. It varies based on disease type, stage of diagnosis, treatment and response to treatment. And so there's a lot of things to consider. I urge you to talk to your healthcare team if you have questions about this. And if you want a better understanding of your own lymphoma and what to expect, this is a really good place to start. Thank you.
Thank you, Dr. Menard, for your excellent presentation. We just have one really quick patient question, and it was about the red flag symptoms. So those are unexplained fevers and night sweats. If you have these symptoms, what does it mean that your lymphoma is more serious or more advanced?
It's a really good question. So we usually think that those symptoms mean that you're dealing with an aggressive lymphoma. So it might not mean that the stage is more advanced, but it would mean maybe that the lymphoma is dividing more rapidly or is more active.
Okay, well, that makes sense to me. Well, thank you so much for joining us today. And everyone, please stay tuned for the next session starting in a few minutes.